Okay. Thank you very much, Josh. I think I'm now sharing. Yeah, I can see that I'm now sharing the slides. So, yes. Oh, I think somebody's already raised a hand, but I'm not sure. It's disappeared. So we'll. Any questions? Just let us know. But yes. So we're going to be talking today about simulation. I've just realised that I'm actually quite far through the slides because I've clicked back through them before. So the first thing we want to say is, welcome to our session. We're talking about simulation today. Just to note though, before we start, this is workshop 1 of a 2-part workshop. So if you are interested in doing the second part of the workshop, which will be a deeper dive into discrete event simulation, then you can still register for that now. There are limited spaces for that one because we're going to be using an online platform and we just don't want to overload it. We want everyone to have a good experience with it, but there are still some spaces. So if you haven't clicked to join that one as of yet, then there still are some spaces for you to join. So just a little bit of promo before we start. So right, let's start off with why simulation. I think that's a good starting point. And what you're going to be walking away with at the end of this hour. So at the end of this session, we want to basically take you through what simulation is and give you some intuition about when it's appropriate to use it as a tool. And then we're going to talk a little bit about how we've used it in the past and in impactful cases in healthcare. So you kind of start to get an idea of how these simulation projects come together and how people actually use the results from them. And then in the second hour, if you were to join us, you'd be looking at the inner workings of a discrete event simulation. We'll give you some resources on how you can get started, and then talk a little bit about open simulation and why you should be striving for open source and open simulation. Okay, so if you haven't heard of simulation, which is actually totally fine, that's where we're kind of starting with as a baseline, then you might be wondering what it is. And what we define as simulation, or what myself and Sally think of simulation is something that will mimic the real world. So we're aiming to, when we're doing a simulation project, build a model that will mimic what happens in the real world in a computerized model. This is often at lower granularity than the real world, because if we, it would take a long time and it would be very complex. There's lots of complexities in the real world, and often you don't need to model every single tiny little bit of intricacy of the real world to be able to answer the question that you're interested in. So that's why I've put this quote on the slide, that every model or everything should be made as simple as possible, but not simpler. That's what Einstein said, and that's kind of what I think about when I'm trying to decide on the level of granularity to include within my model. So really, we're just creating something that mimics the real world and asking it questions. So by building a model that we can then validate and show represents the real world well, we can then start to do things like what-if style scenarios. So we can start to change the model to play out interventions in the system or expansions of the system, etc. So real scenarios that we might not want to actually play out in the real world because there is a risk that comes with changing the real system. For example, patient care or expense, or even hazards that come with changing a real system. So by doing these what-if scenarios in the model of the system or the simulation of the system, we're able to experiment in a risk-free environment, create defensible evidence that we can then use to back up why we would actually do the change in the real system itself. Okay, so all of those things culminate and come together to give us what I think simulation is in essence, which is a tool that provides evidence-driven decision-making or aids and backs up evidence-driven decision-making. So when should you use it? I often think about using simulation in three different ways. So once I've built my simulation model, I might be using it just to, as an individual, to test intuition about what impact interventions might have, or looking to explore the system to look for what's important in it, i.e. if I change some parameters around, how sensitive are my model outputs to those parameters. But if you were thinking about it in a decision-making setting, then it could be used for bringing people together to try and collectively decide on interventions and then look at the impact of them, so collective decision making. And then I think probably third and most important, it actually provides the evidence that will allow you to evidence your future plans. So you can predict what you think might happen in a scenario that you've not seen yet in the real world, and use that to decide whether it's worth doing or not in the real world. Okay, so I'm just going to quickly introduce 3 different types of simulation that you might use in different ways. Oh, have I stopped sharing? I think my slides have disappeared, so I'm just going to try and do that again.
Yeah, I'm just getting ready to share mine, but I was a bit early.
No, don't worry, that's fine. There we go. Right. Okay, so we're going to talk about 3 different types of simulation today. The main 2 that we're going to focus on, and that's because there are areas of expertise, are discrete event simulation and system dynamics. But another type of simulation that you might have heard of is agent-based simulation. So I'll start off with that one because probably all I'm going to say about it today is a high-level overview. But really, when we're thinking about agent-based simulation, we're thinking about individual actors in a system, and we're looking at how they interact with each other. We're trying to think about behaviours and characteristics of the people in the system, and then what happens when they come together and interact. So really, agent-based system is really good for looking at emergent behaviour in systems where you have lots of different actors or entities, which we could think about as potentially patients in a hospital, for example. The other 2 types of simulation are discrete event simulation and system dynamics. So in discrete event simulation, we're thinking about a stochastic system, so something that's got lots of variability in it. We're thinking about patient pathways or viewing the world as a system of cues, for example. It's really good in the healthcare system, particularly at looking at people moving through a system, maybe patients moving through an emergency department or patients moving through treatment pathways. And as I said before, one of the main characteristics of it is that it allows us to look at variability. So it's got stochasticity in there. The way that one patient acts it will vary from day to day. It will vary from person to person because people carry different attributes. System dynamics, on the other hand, is a deterministic type of simulation. So it doesn't simulate any variability, but it's really good for high-level population-style modelling, and it looks at the system as basically a flow. So anything that you might think of as something where there's a flow through a system, you could probably represent really well with system dynamics. So we're less concerned with individual patient movements in that system, but we're thinking about where they are in the system over time. Okay. So those are the 3 types of simulation I tend to think about. There are other types of simulation out there, like Monte Carlo and micro simulation, for example. The reason I tend to think about simulation from these 3 different kind of perspectives is just because these 3 different perspectives, to me, match the process physics of many different healthcare systems. So I find them to be really good starting places when I'm trying to tackle a problem and trying to fit them within one of these envelopes. So I'm now going to pass on to Sally, who's going to tell you a little bit more about system dynamics.
And trying to get the seamless screen swapping around, but that didn't work. We'll go to that. So system dynamics is a bit of a Ron Seal description. So it's an approach to understand the behaviour of the system as a whole and how it changes over time. So a system likely to be complex. It's made up of interconnected parts. And what we discover, if you can map it out in a system dynamics way, the behaviour of the system is determined by how the different components interact with each other. So we're less bothered about what each component actually does, but it's how it interacts with all the other different components. Within our toolkit of system dynamics, we've got two main bits. One is qualitative, the system mapping. and causal loop diagrams. And this just gets an understanding of how the different elements are related to each other. If a change in one part of the system will cause a change in another part of the system, and we map that. So in this diagram here, we can see, looking at our bed occupancy, if the bed occupancy goes up, then that is likely to cause an increase in the size of the waiting list. And if the size of the waiting list goes up, then that is likely to cause a reduction in the referral rate. So within that, we've got a feedback loop. And by mapping out a whole system, you can identify different feedback loops, which ones are balancing and which ones are reinforcing. More of interest to us are the quantitative method, which is a stock flow model. So by actually putting numbers to this, we can see how the behavior changes over time. And we represent stocks with, on this diagram, we use a little, just a rectangle. So stock will be something that accumulates. It could be people, patients, beds, money. And the only way that that level of that stock can change is with the flow in and a flow out. And so we map that and again show the things that affect the flow rates. So system dynamics is good, but it's not good for everything. So if it's the only tool in your toolbox, you probably want to expand your toolbox. It is good for long-term aggregate behavior. So we're looking at averages of flows. As with the other simulation methods, it's really good for testing what if, to testing interventions. It's cost-free, it's risk-free, and we can just try out different scenarios. Quite often in a system, one part of the system will make a change, and then for a good intention, and at that part of the system, it might make that change, but unknown to them, there are unintended consequences upstream or downstream. And so mapping out the whole system can help highlight what unintended consequences might be caused by a change. And it's also good to show the whole system, so communicate the mental models of what your system looks like. So very often, particularly in complex systems, people know their own bit of it really well, but don't really have an appreciation of what's going on upstream or downstream. So if we can map it and demonstrate that yes, you might be working in this part of the system, but this action affects other bits of it in this way. Just gets an appreciation. You don't want to use system dynamics if you're looking at highly discrete events. So if there's a lot of stochasticity around it, then system dynamics is not the right method for you. So we wouldn't want to use system dynamics to simulate an emergency department, for instance, because there's so much variation about time of day and day of the week. We also don't want to use it if there's a lot of variation amongst the characteristics. So we use averages. If that average is coming from a really big range, then it's probably not going to behave or like reality. And then also, again, the stochastic element, the rare or the random events, if they're a big element of that system, then it's not going to mimic it. It's not going to simulate it very well. It's also not very good for small numbers, just because, again, you get that high variability. And if you don't really know what your system looks like or how things are related, then you can end up mapping the wrong thing. So you've got a great tool, you've got a great simulation model, but it's actually not close to reality at all. Over to Lucy. I don't know if you want to do swaps. Lucy, you're muted.
Just going to say there was a question in this in the chat that I think you might be able to type back to Sally. So just whilst I'm talking about discrete event simulation. So okay, so we've given you a little bit of a snapshot there of what system dynamics is and what it could, when it could be used, when it's good to be used, and when it's potentially to be avoided. I'm going to try and do the same now for discrete event simulation. But I want to kind of talk a little bit as we go through with this example that I've got at the bottom of the slides here. So this is something that I'm going to be returning to, this simple example, as part of the second part of the workshop. So it'll be kind of like a little bit of a running example, but as I introduce discrete event simulation, I thought I might as well do it in the context of an example that we're going to be trying to work with later. So as we look at this system, so what we can see here, and I don't know if, I think you can see my mouse moving. So what we can see here is a very simple queuing system where we have an arrival or a patient that comes into our system and is assessed as being a trauma or a non-trauma patient. And then after they're assessed as being trauma or non-trauma, they then go through a number of different activities. And for each of those different activities, there is a resource required to actually carry out the activity. So a hospital resource like a nurse or a treatment room. And then they flow out to discharge after having gone through some or all of the activities that you can see. So that seems really simple, right? Doesn't seem like something too different from that you might see in part of an emergency department, for example. And so you can see already there that through this kind of map of logic, what we've got is a conceptual diagram of a realistic system that we would then try and simulate. So let's go into like the different elements of that. And basically everything that you can see here is a core element of simulation, and there's not many other core elements of simulation that aren't explored in this very simple model. So that's why I like this example, because it in a very simple way kind of provides a view of all the different types of behaviour that we can get in discrete event simulation. So the core elements that I see a simulation making up a discrete event simulation are entities that flow through the system. So in this system, that is the patients that are entering the model and then flowing through it. So those entities within our discrete event simulation, we can give them different attributes. So we can say let them carry with them an attribute of age, or let them carry with them an attribute of ethnicity or IMD status, etc. Anything that you can think of that might impact on the way that they flow through the system could be something that is carried with them. And then that can play into when we get into these different logic gates where we decide whether to go one way or another. Those attributes can be used as part of the model that decides whether they go one way or the other. Okay. There's different states that people can be in. So when they go into an activity, their state changes. So, for example, that when they're in registration, they are in the registration state, and they're in that state for as long as it takes to actually complete that activity, at which point their state changes, and then they go on to examination, and that's the state that the patient's in at that time. And I also put attributes under states as well, because sometimes an activity can actually change the state of one of our patients as well. So, for example, they could have a flag in there that tells you when they've gone through registration, or a flag that they're carrying that tells you when they've been assessed as whether they need treatment or to be discharged, for example. So we can carry information with our entities as they flow through the model. We have an event log. So I think this is probably the most important part of the simulation. So the event log is a list of what happens next in time order. So really, the powerfulness of discrete event simulation is that because we only ever need to know what's happening next to a patient, or so if I'm a patient coming into the system, all I need to know is anything that could happen next to that patient. I don't need to know any of the other bits of the future for them until they actually go to their next event. And at that event, I'll then figure out what are all the possible things that could happen next to them, work out the times to them, and then I'll execute the shortest of those times. So what you can see in discrete event simulation, when we've got an event log, it's basically telling us where to hop to next. So, and that's why it's kind of called discrete event simulation, because we're hopping from discrete event to discrete event in time. So really, really quickly, we're cutting out, in a continuous time model, you'd have to simulate where the patient is at all points of time. Whereas in discrete event simulation, we're cutting out those middle bits. We're only ever simulating what happens next. And when we get there, does anything change? And if it does, simulate what happens, what could happen there, and then update our event log, and then hopping forward again in time. So it's kind of like leapfrogging through your time of simulation from one point to the next. And in that way, it can be really, really efficient, and it can be really, really quick to actually do, because all we're actually doing is updating that event log every time we change a state, we have another event. Okay. Another important part of the actual of the model is the structure or the logic or the routing. So you need to make sure that when you have when you're doing a simulation model and you're building a discrete event simulation, that you have mapped your system well, and that you've represented all the important parts of the actual system logic that you want to represent. So that's more to do with model fidelity and how closely you want to match your real world to your actual simulation model. As you can see in this system, it must be a massive simplification of the real world, because really probably trauma pathways aren't this simple in reality. But if it's as simple as it needs to be to answer the question that we are asking of it, then that's enough. Okay, and then the other element of it, as I mentioned before, it's got stochasticity. So usually when we are in a system like this, a patient will arrive at the system, and then there'll be a probability that they go down one route or the other depending on the attributes that they've got. So the version of reality that patient sees, or the version of the model that patient sees, if they'd have entered it at another time, they could have seen a completely different reality. So it's the probability distributions that govern how they flow through the model. And that's why we never just take one trajectory from a discrete event simulation model and treat it like it's the truth. We run our simulation model many, many times. Sometimes that could be hundreds of times, sometimes it could be thousands of times, depending on how noisy your simulation is. But we generate lots and lots of different trajectories or pathways of people traveling through the model, and then we average across those and use confidence intervals to describe the metrics that we're actually interested in. So once you've looked at this system, you might be interested, for example, in how long people wait in the stabilization activity before a resource becomes available. If we did this simulation thousands of times for thousands of patients, then we'd start to get an idea of, well, what's the average time that they wait? What's the confidence interval of their waiting time, for example? Okay, so I think there, by kind of giving you that description, I've given you a bit of an overview of the main elements of a discrete event simulation. What is it good for modelling? Well, as I've said, and in this example you can see, it's good for modelling patient pathways, or to the level of granularity where you're interested in individuals going through a system. I like it for looking at things like capacity and resource allocation, resource utilisation. So looking at kind of strategic type questions. For example, have I got enough capacity in this system to be able to treat people within the waiting time target that we've set? Or do I need more resources to do that? Do I need more space to do that, for example? So you can start to see that in this system, we could do a what if scenario where we add another cubicle onto treatment to see the impact of that, for example, to see what that does to our resource utilisation on average. Okay. All right. Okay, so we're going to come back to this example in part 2, where we'll go into it in a little bit more detail. But for now, we just wanted to take you through a little bit more about what a simulation project looks like at the strategy unit, because the actual simulation bit itself isn't the whole picture. So, Sally, can I hand over to you?
Yep, I'm just waiting for it to come up again.
I've seen there's some questions. I'll type back to them in the chat.
So Ideally, the structure of a project would be a nice linear process. 4 main parts. Starting at the top left, we've got our model conceptualization. So this is a client coming to us and saying, we've got this problem. And they don't often come and say, we've got this problem and we want the simulation model for it. It's broader than that. And it might come into the strategy unit mailbox, and different teams will look at it and somebody will go, I think this might be suitable for simulation. So from the start, the client may not necessarily know what simulation is. They can come and say, we've got this problem, but actually you need to get down to the root of what that is, and it might be different from what is they're first presenting. So you need to work with client and stakeholders, ideally through some kind of workshop, to really understand what the issue is. Once we've done that, then we develop a concept diagram. Depending on which methodology we're using, that could be, if it's a system dynamics, we might have an outline structure of what the pathway would look like. And discrete events, it could be the logic model. Then we would work through specification and what are our boundaries, how big is this, what is the system. So with system dynamics, we don't want it to get big because it just gets really, really complicated and complex and overwhelming, really. So I'm always trying to keep it as contained as possible and add the detail within it rather than making it really big. So try and tease out what the specification is, what data we need for it, and where those sources are. And then develop a prototype. Does it work? Is the logic right? Are we getting the data in it? Is it decent quality data? And then test it. And at the strategy unit, we don't want to do this on our own. So we want to do this in a participative approach. So the whole lifetime of a project, we've got our stakeholders coming along with us. So a workshop might have 10 or 20 stakeholders in it. We tend to have a much smaller group that is with us kind of on a weekly or every couple of weeks. We're checking in, giving them updates, because we're maybe the experts in modelling, but we have, at the start of it, we have next to no domain knowledge about what it's about. So it's really bringing everyone's expert knowledge into this rather than just relying on us kind of going out and learning everything. So we develop a prototype, we test it, issues will come up with that, we refine it, check that if everything's working great, that's fine, and then we can actually populate it, get it run properly, validate it. So is the model behaving like reality? And then kind of pass it off back to the stakeholders for it to be used. And it would be great if it was just one loop of that circle and everything went swimmingly. But as with everything else, it isn't like that. And you can go round and round this. You can go back and keep going back and keep having to rework things. So the case study that I'm going to talk through in a minute, we got round to the validation of the model, and the validation was not great. And the reason for that was all to do with the data sources we used. We were depending on Health Server for England results that got published while this model was being developed, and actually they weren't useful. So we've had to go right the way back, kind of backwards, and rethink the data spec and data collection. So you have to accept that, yes, ideally you go around this in a clockwise direction once, but you're going to be backwards and forwards and iterating a lot of the time. So next we move on to making the impacts. We've got 2 case studies, one using each of the 2 simulation methods we've talked about. So the first one is modelling chronic kidney disease, which we talked about the renal pathway, renal services yesterday afternoon. So if you were at that, you have a brief overview of part of it. So we were asked to, as part of the renal services project, a big part of it was understanding the chronic kidney disease pathway and how people will flow through that, some worsening to the point that they need kidney replacement therapy. So CKD, I'd never really heard of it until this started. It's a progressive disease. It's symptomless in its early stages. So people who are diagnosed with it early on is normally through some other disease or some other presentation. But it is a big issue. There's about 11% of the population in England aged 35 and over have CKD from stage 3 onwards. And an awful lot of them are undiagnosed. They're not aware of it. It's very linked to obesity, to type 2 diabetes and high blood pressure. And most people will have CKD at stage 3 and it doesn't progress and their lives are relatively good quality of life with it. But a small percentage will suffer with kidney failure and requiring kidney replacement therapy. Overall, it is an expensive disease. So at the minute, it's about £6.5 billion per year, but that is projected to rise if we don't do anything different. And that's through an aging population and just with the changing demographics. So something needs to be done. But there's such interconnectedness of things that what does it look like if we do certain things? So a bit of the timeline here. I've put May 2024 as the start of the project timeline. It actually started a year before that when we had our first discussions with the client. But then things went quiet. But it all really kicked off again in May of last year. So we started with that workshop, defining the problem as an in-person workshop with clinicians, so hospital clinicians, kidney centres, so the dialysis and transplants, the nurses from that, primary care. So trying to get a full range of what the kidney pathway might look like in that workshop to understand what the problem is. To start with, kind of went to plan. We developed a structure, had a workshop about that where refinements were made, populated it, and so that's when we had a big stumbling block with data. So September 2024, Health Service for England published their findings from the 2022 survey. And we put the model was built around that, expecting that data to come in, and it just didn't work. So had to kind of go back kind of 180 degrees around that project life cycle again and have a rethink about what data we use and how to feed it in. And eventually we found something that was much better at mimicking reality. So January this year, we had that validation workshop, again with that wide range of clinicians, and there was acceptance around that. And then it had a very soft launch because it's tied in with discrete event element of it. So the CKD tool was softly launched about February, March-ish, but then went very public in July of this year. So it took longer than we planned. It was meant to be completed within the previous financial year, but due to the barriers and hurdles that we came across, it just stretched out with that. So I mentioned barriers. We've had a few with it. One of them was a change of staffing within the strategy unit simulation team mid-project. So there was 3 months between Lucy's predecessor leaving and then Lucy starting, and that slowed things down a little bit. As I mentioned already, the big barrier was the data sources and definitions. So we use a lot of published papers to help support the work that we put into it, but it's very different papers, different projects have used different definitions of what counts as a diagnosed CKD. So there's a bit of issues there about trying to get it to fit. And and just transparency about these projects that were funded by pharma. They put so much in the papers that are published, but there's an awful lot that isn't, and it's difficult trying to get information around that. The validating and calibrating of the model, again, linked with that, the data issue, start slowing things down. And then this level of granularity that was asked for versus what's available. So with CKD, the disease, different ethnic groups have different flow rates through, particularly to the serious, so stage 4-5 CKD and onto kidney replacement therapy. So ethnicity is an issue in it. Different ethnicities flow differently, but the data isn't available. One of our main data sources is CVD Prevent, which is updated quarterly, but they don't report ethnic groups on that. So it's something that we're hopefully in the future, if we get more funding for it, we can try and look into trying to include that into a future model. So what about the end result and the impact of it? So we created a tool rather than just a one-off, here's a report, you asked us to do something and here it is. We created a tool. It's freely available just through a web link. It's open, so anyone with that link can go and use it. And it's been designed as a self-service tool, which is important. So it's rather than just a project coming to an end with a report, actually it's turning into a bit more of a product. And hopefully we can maintain that and update it into the future. When I wrote this slide, we had over 2,800 runs, but since we highlighted it yesterday, it's gone up to 2,900. So we might click 3,000 by the end of this week. It'd be great. And there's a range of people using it. I don't know who's using it. I do know that we've had clinicians use it. People from ICBs are using it, commissioners, but there's other people as well. It's being used to support business cases, and it's also being used and sparked interest in people from other areas who like the methodology and are looking at it for other disease pathways. So the fact that we've made it open, it's available, people are aware of it now and think, oh, I wonder if we could use this for this other CVD diseases have been an interest in. And just the structure of it, people are going, oh, I wonder if it could fit with us. So that openness, and Lucy's going to talk about it later on, I think is a really, really key thing about selling a simulation. I suppose it is a tool now at the end of the day. I'm going to pass over to Lucy to talk about her case study.
There we go. Okay. And I'm off mute, so that's good. Sally, there was a few questions that somebody's asked for the link to the tool, which of course we can share. And there was a couple of SD related questions in the chat as well. So if you get a second, can you have a look at those? Fab. Okay, so I'm going to tell you a little bit about another case study. The reason we've kind of tried to weave some case studies into this workshop as well is I think sometimes learning about how simulation is useful and when is easier in context. And there's a lot of the method that we can only, can't squeeze loads of teaching into 1 hour. So if we can just show you a little bit about how and when these have been useful to us, these tools, then hopefully you can take that away. Now, for myself and Sally, we are part of a bigger analytics and modelling team. So simulation isn't the only kind of feather in our bow, let's say, or feather in our cap. That's what they'd say. So we can, it's not the only thing we ever use on any problem that comes up ever. But it's nice to show you a couple of examples where it's gone really well and it's been really impactful doing so. So I'm going to talk to you a little bit now about a project I did with Northwest Air Ambulance. This was actually from prior to when I joined the strategy unit. So I worked at Lancaster University as an academic for a few years, and whilst I was there I did a consultancy project with the Air Ambulance just to try and answer a few of their questions. And when I say a few of their questions, so the Air Ambulance were they are just so interested in research and they are so evidence driven. I was really surprised and taken back by them as an organisation. So loved working with them. This was a great project. But when they came to us, because they had quite a few questions, the first thing that we had to do as analysts was to try and fathom what we were going to work on first. So there was questions about, are our base locations correct? When should we fly our aircraft? Should we do a 24-hour service rather than the flying within the hours of daylight that we're doing now? Why are some of our missions being stood down compared to other missions? Are there features of the missions that are leading to those stand downs, for example? Because it costs them a lot of money to get their aircraft off the floor. So really, they were just trying to use us as analysts at the university to really dive into their problems that were operationally relevant for them. So I thought that was amazing. And we ended up doing 3 projects with them in the end, and they were all really really interesting. But this one I'm going to talk to you about today is simulation based. So when we kind of had done that kind of problem definition, after we'd done the problem definition style tasks, we kind of narrowed down that the first project we were going to work with Northwest Air Ambulance on was looking at when do they run a service. So they work all year round, but they only work during the hours of daylight. And they had an opportunity coming up at that time, which was 2020, to do a new contract with the helicopters that they had, and they were thinking about hiring some aircraft that could fly at night, but they were more expensive, so they kind of wanted some evidence to tell them that that was the right thing to do. And in winter, because it was going to winter, it can really impact the hours that they can actually work, because they could only work between hours where there was actually daylight, and in the winter obviously we get less daylight, so they'd have to stop between 4 or 5 p.m. or even earlier on some days. So they wanted to know what would be the impact if we extended our operational hours during the night, and on top of that, what schedule should we run, and then on top of that, which of the assets should be on duty. So because they had a number of different assets. So what I've got here for you is just a picture of their 2 different bases within the Northwest West region. This one's at Blackpool, and this one is in Barton, which is very near to Manchester and also quite close to Liverpool as well. So the Barton base is very close to some high populous areas, and the Blackpool base is kind of good for going up into the Lake District and kind of this more rural country in between. Okay. So the simulation model that we actually built for them in the end was very, very simple, but the simplicity of it matched the question that was asked. So it was powerful enough to answer their question, give them the evidence they needed to decide on what to do, and it was easy to validate because it was a very simple style model. So all we had was this linear system. So it was much more simple than the treatment pathway model that I've talked to you about before, where there was decisions over routing and things like that. Because in this system, basically each job was its own entity. So if a job arrived to, they got the call from the ambulance service saying we need an air ambulance to come to this job. They'd then allocate an aircraft to it. There'd be a mission time for them to complete the actual mission, and then they'd leave that mission, and usually that would be at the point where they drop them at the hospital, or it could be if they've treated them at the side of the road, it would be the point where they'd flown back to base, so they were ready to go again to another mission. So if a call arrived whilst all the assets were busy, unfortunately there weren't enough assets to do that job. So that job, it was not like they could wait around for an air ambulance. They'd do the air ambulance is like on top of the normal ambulance service. So a normal ambulance would be going out to that job anyway, but the air ambulance wouldn't be able to go. Okay, so the 2 stages to the project. There was trying to build a model of their current operations that happen in the hours of daylight. And then step 2, looking at what could be done at night, but obviously we had no data there. So we had to kind of infer the number of calls that they would get at night by comparing the number of calls to the Northwest ambulance services that were completed by the air ambulance in the day, and then using that as our factor of the number of calls that the ambulance service received at night that the air ambulance would take. Okay, so the first part of the model, we were just validating our baseline model. We looked at the utilisation of the aircraft through the day, and we built a simulation model use the air ambulance data to fit distributions for the arrivals of calls and the length of the mission times. And when we'd done that, we looked at the utilisation of our simulated aircraft, and they matched pretty much, very well to what we would expect given the what we'd seen in the air ambulance data. Then we did what inferred the need for Northwest Air Ambulance at night, and we took the 0.5% of calls that came into the ambulance service that the air ambulance would do in the day, but then we took into account that the fact that at night time there might be extra limitations on the calls. So maybe the number of calls that we can do in the day is a bit too optimistic to think about the number of calls we'd do at night because of the distance that we might need to travel if we are using a rapid response vehicle asset over an air ambulance, or maybe the weather at night is worse and the landing facilities are harder. You have to have a much larger landing area at night for an air ambulance. So it really does limit where you can actually send your missions out to. So we took all that into account, and that led us to create some scenarios with the guidance of Northwest Air Ambulance, and we included them within the process throughout that to actually guide us to those scenarios, and those were the ones that we ran. So and what you can see here is just basically the output of those scenarios. So we looked at a 4-hour and a 10-hour shift. Our baseline was if they received all of the 0.5% of calls from the Northwest ambulance service. If 0.5 was going to the air ambulance, then what would that mean? And then 75% of that and 50% of that, just to kind of think about the limitations of the missions because of different factors like assets and weather, etc. And you can see that in the 4-hour shift, on average, they'd be doing an extra job per day. And the 10-hour shift, they'd be doing up to almost 2 extra jobs per shift if they were to do that. So even in the worst case scenario, we're seeing they're doing an extra job each time. And to them, saving an extra life on average was enough for them to want to do something about it. So given our analysis, they trialled missions up to 8 p.m. using a rapid response vehicle during the hours of darkness in 2020. And they actually saw some very similar results to one of the scenarios that we had run. Which gave them even more confidence that the simulation and the evidence was backing that they should do this. And more recently, so I went to an air ambulance conference a couple of weeks ago, and they said that they now run the rapid response vehicle from 6 p.m. till 2 p.m. 7 days a week. And recently they've seen that that's led it to a 28% rise in the missions thanks to their night car. So that's another important part of this. We said to them that using a rapid response vehicle, instead of taking on the cost of buying the air ambulance that then you might struggle to land places, the rapid response vehicle in the evening in the populated area around Barton, such as Manchester and Liverpool, is actually going to make quite a bit of impact because they're places where you're likely to see quite a few different accidents during the hours of darkness. So so it was a really nice project, and as you can see, they've actually used the evidence to build up their use of this night car throughout the years. Okay, so in summary, because we've got 5 minutes left, so we're going to take some questions in a second, but you've basically, in this session, you've heard a little bit about what simulation is and when it can be used, and we've tried to intuitively give you ideas of when to use each different type of simulation, and then we've given you some examples of how it can be used and how we have used it to make impact. So let's have a little look at the questions. Again, join us in the next session if there's still spaces, because we'd love to have people learn a little bit more about DES. So let's go just deep. Is there any questions that are crying out already, Sally, or?
I've tried to answer the system dynamics ones. So a few questions there about what software I use. So I use a piece of software called Stella Architect, which is proprietary. You pay for the software once, and then we pay an annual support package. So if money is very tight, you can buy it once, and then you don't get updates after the first year. And then the nice thing about Stella is that it allows you to create that front-end interface, which is what we've hosted on their repository. The other main system dynamics software is Vensim, but it doesn't have that interface element to it. And then somebody asked about the free and open source one. So there is a site called Insight Maker, and I've answered it in someone's Q&A, which just requires you to register an account with them, and you can build system dynamics models there. They used to have a workbook, and I can't find that anymore. But you can see other people's models on that, and just to get an idea of how they work.
If I could come in on that, on the Des side as well, to maybe, did you finish what you were saying there, Sally? Because I don't want to cut you off.
No, you go on. You go
on. For us, and I don't know if the question was specific to system dynamics, but if you're interested in what we do for Des generally, or what we're trying to do for discrete event simulation, is we have previously been using commercial software, but we're trying to move away from that now, because we realise that actually it's expensive to expect our clients to buy that if they want to use the model after we've created it for them. And we're trying to move towards doing more model reproducibility. I'm going to touch on that a little bit more in the next session, but what I mean there is, if we build a model, I don't want it to go out of date just because it's been built at a snapshot in time. So we're hoping with our renal model to get more data from UKRR, the renal registry, over the years, that we can then feed into the model and keep updating it. So reproduce that model, update it, reuse it every year, so that it can be then used within planning, used for evidence-based decision making, and improved upon over the years. So to do that, we're going to more open source modelling type software. I use open source. Basically, we're using SymPy at the moment to rebuild that model, and in future we're going to try and work with SymPy just kind of as a standard going forward for discrete event simulation. And I think we can do that here because of the support of our amazing data science team, who are helping us to make sure that when we're building those tools, we're doing it in the right way. And so we're in charge of the logic and the simulation-y bits, and they're in charge of the making sure that it's the right, correct architecture, and that it all it ticks all the boxes, and it looks after itself. So yes, somebody's just mentioned there, Sim is an R package similar to SymPy if people are interested in more R learning. The reason we went for SymPy over Simmer personally was because I know that there are developments in